Focus on head injury. Head injury includes any injury or trauma of the scalp, skull, or brain. Head trauma has a high potential for a poor outcome. Deaths from head trauma occur at 3 points after injury, immediately after the injury, within 2 hours after injury, and about 3 weeks after injury. Deaths occurring within a few hours of the trauma are caused by progressive worsening of the brain injury or internal bleeding. A contusion is bruising of the brain tissue within a focal area, and it is usually associated with a closed head injury and often occurs at a fracture site. A contusion may have areas of hemorrhage, infarction, necrosis, and edema. Contusions may continue to bleed or re-bleed. An epidural hematoma results from bleeding between the dura and the inner surface of the skull. An epidural hematoma is a neurological emergency. It is usually associated with a linear fracture, crossing a major artery in the dura, causing a tear. It can have a venous or an arterial origin. Venous epidural hematomas are associated with a tear of the dural venous sinus, and they develop slowly. With arterial hematomas, the middle meningeal artery lying under the temporal bone is often torn. Hemorrhage occurs into the epidural space, which lies between the dura and the inner surface of the skull. Because this is an arterial hemorrhage, the hematoma develops rapidly. Classic signs of an epidural hematoma include an initial period of unconsciousness at the scene. This initial period of unconsciousness is followed by a brief lucid interval, and that is followed by decrease in level of consciousness. Other manifestations of an epidural hematoma may be a headache, nausea and vomiting, or focal findings. Rapid surgical intervention to evacuate the hematoma and prevent cerebral herniation, along with medical management for increasing intracranial pressure, dramatically improves outcomes. In this diagram, we see an epidural hematoma. Once again, it results from bleeding between the dura in red and the inner surface of the skull. This picture also shows us the next topic, a subdural hematoma. Over here on this side of the slide, we see the subdural hematoma. It occurs from bleeding between the dura mater, again in red, and the arachnoid layer, shown in yellow. Okay, so here with the subdural hematoma, we have bleeding in between the arachnoid as well as the dura mater. In this picture, we see an epidural hematoma covering a portion of the dura. Multiple smaller contusions are seen in the temporal lobe. A subdural hematoma occurs from bleeding between the dura mater and arachnoid layer of the meninges. A subdural hematoma usually results from injury to the brain tissue and its blood vessels. The veins that drain from the surface of the brain into the sagittal sinus are the source of most subdural hematomas. Because it is usually venous in origin, a subdural hematoma may be slower to develop. However, an arterial hemorrhage can cause a subdural hematoma, in which case it develops more rapidly. Again, because the subdural hematoma is usually venous in origin, it develops much slower to develop into a mass large enough to produce symptoms. Subdural hematomas may be acute, subacute, or chronic. An acute subdural hematoma manifests within 24 to 48 hours of the injury. The signs and symptoms are similar to those associated with brain tissue compression in increased intracranial pressure. They include decreasing level of consciousness and headache. The size of the hematoma determines the patient's presentation and prognosis. The patient's appearance may range from drowsy and confused to unconscious. The ipsilateral pupil dilates and becomes fixed if intracranial pressure is significantly increased. Blunt force injuries that produce acute subdural hematomas may cause significant underlying brain injury, resulting in cerebral edema. The resulting increase in intracranial pressure from the cerebral edema can increase morbidity and mortality, despite surgery to evacuate the hematoma. A subacute subdural hematoma usually occurs within 2 to 14 days of the injury. After the initial bleeding, this hematoma may appear to enlarge over time as the breakdown products of the blood draw fluid into the subdural space. A chronic subdural hematoma develops over weeks or months after a seemingly minor head injury. They are more common in older adults because of a potentially larger subdural space from brain atrophy. That's a normal change that occurs with aging. Some brain atrophy occurs. With atrophy, the brain stays attached to the supportive structures and tension is increased. This makes it subject to tearing. Because the subdural space is larger, the presenting problem is focal symptoms, meaning they're specific to a certain area of the brain rather than signs of increased intracranial pressure. Patients with a history of alcohol use are prone to subdural hematomas because of an increased incidence of falls. Diagnosis of a subdural hematoma in the older adult may be delayed because symptoms mimic other health problems in this age group, such as confusion, lethargy, and memory loss. The manifestations of a subdural hematoma are often attributed to vascular disease, such as a stroke or a TIA, even dementia. There can be a delay in diagnosis of a subdural hematoma in older adults. Once again, this is because the symptoms mimic those conditions that can accompany the aging adult, such as stroke and dementia. Intracerebral hematoma occurs from bleeding within the brain tissue. It occurs in about 16% of head injuries. It usually happens in the frontal and temporal lobes, possibly from rupture of intracerebral vessels at the time of injury. The size and location of the hematoma are key in determining the patient's outcome. In general, the diagnostic studies are similar to those used for a patient with increased intracranial pressure. CAT scan is the best diagnostic test to evaluate for head trauma. It allows for rapid diagnosis and intervention in the acute care setting. MRI, PET scans, and evoked potential studies may be used to diagnose head injuries. An MRI scan is more sensitive than the CAT scan in detecting small lesions. Transcranial Doppler studies allow for the measurement of cerebral blood flow and the velocity of the flow of blood through the cerebral vasculature. A cervical spine X-ray series, CAT scan, or MRI of the spine may be done since cervical spine trauma often occurs at the same time as a head injury. The principal treatment of head injuries is prompt diagnosis and surgery if needed. In addition, we institute measures to prevent secondary injury by treating cerebral edema and managing increased intracranial pressure. The Glasgow Coma Scale is a standard system for assessing the level of consciousness in patients who have had head injury. In cases of large acute subdural and epidural hematomas, or those associated with significant neurological impairment, the blood must be removed through surgical evacuation. A craniotomy is generally done to see and allow control of the bleeding vessels. Burr hole openings may be used in an extreme emergency for a more rapid decompression, followed by a craniotomy. A drain may be placed after surgery for several days to prevent blood from reaccumulating. In cases with extreme swelling is expected, for example, hemorrhage, a craniectomy may be done. This involves removing a piece of skull to reduce the pressure inside the cranial vault. It reduces the risk for herniation. A patient with head injury always has the potential to develop increased intracranial pressure, which is associated with higher mortality rates and poorer functional outcomes. Objective data are obtained by applying the Glasgow Coma Scale, assessing and monitoring the neurological status, and determining whether a CSF leak has occurred. Nursing diagnoses for the patient who has sustained a head injury may include ineffective tissue perfusion, cerebral, hyperthermia, acute pain, impaired physical mobility, and anxiety. The collaborative problem to be addressed is increased intracranial pressure.